in South Korea, and the uptake in that country was immense, with thousands of cases having been performed until today. Now, the same uptake hasn't been followed in the rest of the world, namely Europe, UK, and even the United States. So in our study, we want to evaluate how this novel technique applies to our particular population and how it compares to open thyroidectomy. So what we did is a non-randomized study. So we offer the patients the option to select whether they want to go for a robotic approach, transaxillary approach, or for an open approach. And 15 consecutive robotic patients were matched closely for age, sex, BMI, and comorbidities against 15 open thyroidectomy patients. There were exclusion criteria, of course. Any patient who had a nodule of more than 6 centimeters, any suspicion of malignancy, any history of previous neck surgery or neck irradiation were excluded from the study, as were patients that had a BMI in excess of 35 kilograms per meter square. What we evaluated was primary and secondary outcome measures, which essentially included the completeness of the surgery, i.e. whether the lobe was removed, whether there was any need for conversion to open surgery, what were the complications, how this compared between the two groups, and also patient-reported outcome measures in terms of pain, scar cosmesis, voice, and also quality of life. Now, if we look at our results, in all 30 patients, the thyroid lobe was successfully removed, and there was, in the robotic cohort, there was no need for a conversion into open surgery. With regards to complications, there were no complications in the open cohort. In the robotic group, however, there were 2 complications. There was a neuropraxia of the recurrent laryngeal nerve that quickly resolved over the course of a few days. But also there was a brachial plexopathy, which took several weeks and intense physiotherapy to resolve. Following this, we decided to change the position of the arm of the patient from what Dr. Chang initially described, from the 180-degree extended position to what we call the extended salute position, where we flex the elbow and rest the dorsal aspect of the palm on the patient's forehead. And we did this with the patient being comfortable and awake, and after we were ensured the patient was comfortable, then they were put on general anesthetic. Following this, we didn't encounter any further brachial plexus injuries, and now we've done more than 30 robotic thyroidectomies, although the data for the first 15 are presented here. Looking at the operative time, of course, and in conjunction with the literature, this was much longer in the robotic group compared to the open group. And if we look at the blood loss, this was more or less the same. Now, with regards to patient-reported outcome measures, quality of life and also voice didn't show any statistical significant difference. However, with regards to pain, there was a trend that favored the robotic patients, paradoxically. This lasted up to 2 weeks following the surgery, and then the pain of the two groups became equal. The big difference, as expected, was in the scar satisfaction. The scar cosmesis was statistically significant higher in the robotic group from day 1 postoperatively all the way to 12 months and even to 18 months now with our extended data. So to conclude this short presentation, robotic thyroidectomy is feasible in a Western, i.e. UK population, despite the anthropometric differences between our population and the Korean population. However, there still needs to be research, and larger trials are required in order to evaluate the appropriate position of the arm and before this is released into the National Health Service. For the time being, we advocate that this remains a practice only of high-volume surgeons in specialized tertiary referral centers. Thank you.
Thank you, Mr. Garas. Are there any questions from the group? I have a quick question.
Of course.
In which patient did you encounter that initial brachial plexopathy? Was it very early? I mean, was it in the first?
It was. So that was possibly also part of the learning curve, of course.
Yeah.
It was, I think it was the 5th or 6th patient where we encountered that, and following that we took a lot of care in terms of how to position the patient.
Fantastic.
Yeah.
Okay. As Marina is pulling up our next poster, how did you assess pain? Because I've actually, whether it's the right thing or the wrong thing to do, I also think that it's a very interesting procedure that might offer an improved technique long-term surgically, and not just simply be about the scar. But I realize this is still a new idea, and this is somewhat a controversial procedure.
Of course.
But I have also noticed this, that sometimes for especially the slender patients for whom the surgery is quite quick, they actually complain of very little pain.
Yeah.
So my question is, although it wasn't statistically significant, you did notice a difference, and that there was a trend toward lower pain.
Yeah.
How did you assess that?
Absolutely. So obviously pain is a subjective sensation, as we all know. However, what we did is we did it twofold. One, we used the visual analog scale, and the second way, we also used the analgesic requirement and compared that between the different patients. So we try to be as objective as possible, but of course this is a subjective parameter, really.
So you recorded their
required
medicine
paracetamol and non-steroidals, etc., and compared if there was any need for opioids or any more analgesia in one group compared to the other.
Thank you very much, George. Congratulations.